Hello, and welcome back to Gemma Network Open Live. I'm Seth Truger, Digital Media Editor of Gemma Network Open.
And I'm Mike Berkowitz. I'm Electronic Editor for Gemma and the Gemma Network.
So thanks for joining us. Today we are talking about the effective exposure to gun violence in video games on children's dangerous behavior with real guns, an RCT, by Justin Chang and Brad Bushman.
Tell us what this showed, Seth.
Yeah, so this is interesting. They did this RCT where they got about 220 kids, basically paired them up, had one of them play Minecraft for 20 minutes with the other one watching them.
Right.
They were randomized to 3 different types of Minecraft variations. Two of them were violent. So one of them had swords and monsters, one of them had guns and monsters, one of them was non-violent, didn't have any violence or monsters or anything like that. Let them play for 20 minutes, and then took the same pair and had them play in a playroom with all sorts of different toys. Also in the playroom, there's a cabinet with a gun or a disabled handgun with a trigger counter.
So it's not a toy gun. It's a real gun, but it's disabled.
A real gun is disabled, not just unloaded, but doesn't have the ability to fire bullets and stuff because, you know, safety and IRBs are stingy about stuff like that, I imagine.
Right.
Appropriately so. And then just basically measured different types of behavior, things like they only looked at the kids who found the guns, which, to be fair, makes sense. And then did they touch the gun? Did they tell adults about the gun? Did they? How much time did they spend touching the gun? Did they pull the trigger? How many times did they pull the trigger? And then did they point it at themselves or their other people while they're pulling the trigger, et cetera, et cetera? There are also surveys beforehand that the kids did and the parents did with things like how much violent media exposure they get in general, some attitudinal stuff, things like trait aggressiveness, and is there a gun at home, gun safety classes, and some other stuff like that.
So one of the unique aspects of this, just to make clear, is that there was a trigger counter on the disabled handgun. So it was outfitted. So it wasn't a video review of how many times they pulled the trigger. There was actually a mechanism by which you could count, the way you count people walking into a room or something like that.
Yeah, that's exactly what I envisioned, one of those little things with a little dial that spins, except instead it's a gun and children.
Right. And the comparison is between whether amongst the kids who found this gun in this cabinet, whether they were exposed to gun violence, non-violence, or sword violence in Minecraft, which frankly I didn't know had violence. I thought you were kind of putting things together and building cities, but that's my
I think the general idea isn't that this was Minecraft, but that they used Minecraft as a platform to do the experiment.
Right. So what did they find? I could predict what they found, but I also am unblinded to the study.
Sure. So what they found is that basically there was a pretty linear association between how much violent or dangerous behavior the kids did with whether they were in the gun game, the sword game, or the non-violent game. So basically the kids who played the gun game had an average of or median of 91.5 seconds of gun contact versus 72 with the swords and only 36 in the nonviolent. The trigger pulls were pretty impressively different. 10.1 versus 3.6 versus 3. So the kids who played the gun version definitely had a higher number of trigger pulls. And also the same thing with the trigger pulls at self or other. So it's 3.4 versus 1.5 and 0.2.
Yes.
I mean, for me, there's also, the big takeaway here, this is, I think, most of the data we have on video games and guns that I've seen anyway, is kind of big epidemiologic stuff, like how much is spent per capita on video games in the US versus Japan and how much overall violence there is in youth stuff. This is kind of the exact opposite of that, where it's not long-term where these kids grow up to shoot people. It's they play a game, right afterwards, they find a gun, what do they do with it? And so, I don't know. I think it's interesting. It certainly doesn't answer all the questions about video violence and video games and media and guns, but it's interesting.
Right. So, and you pointed out that they're only looking at the the young children who found the handgun. So there were 220 children who found a gun.
Right.
And among 76 children who played the video game that included violence, 47 touched a handgun. So what was the total number? The majority of the kids who went into the room after playing found this thing, right?
Yeah, it was 242 who were in the study altogether, and then 220 who found the gun.
Okay.
There were a couple other minor exclusion things, like 2 of them were in another version of the study that had violent movies. A couple of them were outliers in the survey data, so they didn't want to skew their numbers with their kind of small stuff. Some pretty reasonable exclusion stuff.
Okay, and so one of the things that I think I mentioned to you is this study seemed designed in some respects to get the results that you would expect. I wonder what your thoughts are about that.
Yeah, I mean, I think this was kind of this is absolutely a laboratory artificial setting. This is not randomize kids to video games, see what they grow up and do with their behavior. The overwhelming majority of kids found the gun. The question is, what kind of differences in behavior were they when they did find the gun? For me, one of the most interesting stats, and I don't have this broken up across the groups, but it's that over a third of the kids found the gun, or of the kids who found the gun, over a third touched the gun or handled it in some way, but didn't tell an adult at all. And that was the thing that was scary to me. That's the thing when I got home after reading this last week and talked to my daughter. I was like, hey, do you know what to do if you find a gun? If you're at a kid's, friend's house and you have a gun, made sure she knew what to do.
Yeah, you can imagine.
Yeah.
I can imagine having kids and having been a kid that you see a gun and you get worried that you're not supposed to have seen this thing or touched it, and so you don't want to tell a grown-up.
Yep. Exactly. Right. My daughter's she's a little dork, and she was all proud. She's like, "Oh, you don't touch it. You don't touch it." I was like, "What else?" She's like, "I was like, do you tell anybody?" She's like, "Oh yeah, I tell a grown up."
Right. That's called satisficing, giving you the answer that you wanted.
Right.
So the randomization here, just to be clear, was to the different kind of video game. Because I think there was some question in social media over the weekend about whether this was a truly randomized experiment.
Yep.
So the randomization wasn't really looking at the outcomes. It was just to make sure that there were equal proportions of children who were exposed to the different kinds of video games. And the other thing you may not have noticed about this is maybe going to be a controversial study if people catch wind of it, because it clearly has a message that some people might not like politically. These authors are making their data available. They've published their statistical code and the output so that you can see how they came to these results. And they published a data sharing statement saying that if you want to get access to the data, submit a request to them. We at the JAMA Network Open haven't published the data. We don't quite have the resources to do that in a way that we don't have the infrastructure to kind of support that. But the authors say that they'll make those available to those of you who want to kind of see if the results are otherwise or hold up or are replicable. So I think that's interesting. And it's part of kind of what we're about at the journal is making data and findings, science open and transparent.
Yeah, absolutely. And speaking of all the different types of data, if you look at table 4, there's a whole bunch of different things from basically the way they did negative binomial regression models based on the surveys that the kids and the parents did beforehand and just how those correlated. And you can see a couple interesting findings. As kids got older, they were less likely to handle the gun and less likely to pull the trigger. As kids had what they called predicted interest in guns based on whatever variables in their survey, they were more likely to play with the guns. As they had higher violent media exposure that they self-reported, they were more likely to handle the guns. Interestingly for me, the kids who had guns in the home were less likely to handle the guns, which to me speaks, one, possibly, I'm totally making this up, but one, potentially about lack of novelty that they already know, and two is they, perhaps their parents are responsible gun owners and train them properly. There was a small subset of kids who had some sort of firearm safety, and there were some signals. There was some effect of them spending less time with a handgun, but I think that and fewer trigger pulls, not quite enough. My guess is the sample size is too small to not have lower trigger pulls against others, but overall some good signals that things like gun safety worked. And that's really kind of, I think, my biggest takeaway from the study is that safe storage of guns is important, and that if my kid is playing at a friend's house and their parents are gun owners, I want them to be responsible. I want it to be locked up. I don't want my daughter to come across a loaded gun that's accessible and play with it and not touch an adult or not tell an adult, or anything like that. I'm also biased. I'm a pretty avid video game player. I play a fair amount of violent video games. I don't think there's any correlation that I can see.
Right, but you weren't playing as a young child, right?
I was playing pretty violent video games pretty young. I remember a few years ago, I was playing my brother-in-law, and my mother-in-law was there as well. We were playing a popular combat type game, and my mother-in-law goes, "Oh, like what happens to these kids who grow up playing these violent games?" And my brother-in-law doesn't skip a beat and says, "They become doctors and lawyers." He was a lawyer. Yeah.
And what's your take on Fortnite? Because that's the kind of concern du jour about what that game, which I think is pretty violent, is doing to young boys.
Ultimately, I've played a little bit of Fortnite. It doesn't really seem any fundamentally different than any of the other violent video games I played growing up. I tried playing it. It's really frustrating because I don't have the time to dedicate and get as good as the 12-year-olds who run around, and I spend 10 minutes running around foraging for stuff and finally find someone and die in like 3 seconds. But this is stuff we've literally... I've seen, I'm not an expert on these stats, I've seen some stats on video game playing, and I think there's this misconception that it's kids who play video games. Every time I've seen the number, the median age of the video game player in the US is my age. It's me. It's not that kids play video games. It's when we were young, kids play video games. And as we got older, everybody plays video games who's my age and younger.
Right. And what's your take on Twitch? Have you been on Twitch?
I don't know anything about Twitch.
I think Twitch is the social media platform that allows you to watch other people playing their games, right?
I mean, that's just the kids these days being like, why would you watch other people play video games? Like, I've seen like a handful of like funny videos that come across my Twitter feed or something like that. But like, there's only so much stuff that's fun about watching that. It's pretty silly to me to be a video game spectator in any serious quantity.
Okay.
Yeah.
Well, that's a good wrap for this paper. Check it out at JAMANetworkOpen.com. It is the feature article this week, meaning at the top of the homepage. And what do you have up next?
Okay, next we have the prevalence of female authors in case reports published in the medical literature by David Shea and colleagues.
So this is another paper. We have a bunch of these across the network that's trying to kind of establish as a baseline equal representation of women. We've published either in JAMA Network Open or another network journal about kind of women in medical conferences and women on faculty and equal wages and salaries and so on. But this is how women are represented as first or last authors on published case reports, right?
Yep, and this is really interesting. So they looked at every case report with an American author that they could find in PubMed from 2014 to 2015. They only did case reports that had up to 2 patients, basically with the idea being that if it's 3 patients or more, then some IRBs consider it a cohort study or something else more advanced, maybe more rigorous, with the idea being that case reports are generally the easiest type of science to get out there.
Right.
You can do it as a resident. I had a case report when I was a resident that I was, I think, 3rd author on.
There are fewer barriers to entry that might apply to kind of quote-unquote holding women back in more rigorous or intense scientific enterprise. For a case report, you can see a patient that's interesting and put it out there.
Yeah, and there's really not a lot you need to do to go from, hey, I have this interesting case, to do some lit review, put it together, submit it a couple places, get it published.
Right.
So they found 20,427 case reports across 2,500 journals.
That's a lot of
case
counting.
Reports. Yeah, a lot of counting. It looks like it took them 3 years to do all that counting, which I'm not making fun of. That's 20,000. It's a lot of case reports.
Right.
And basically, the general idea is they weren't looking at this at quid pro quo, but that they looked at some basic stats of residents, the number of residents overall versus first authors, and the number of faculty or attending docs as last authors, with the general idea being that first authors tend to be the more junior person who leads a study, and the more senior person is generally the typical senior or last author. And again, just to get some general guidance. But the overall numbers they had, there's about, I think, 35% of docs, or let's see, so 44% of U.S. trainees are women and 34% of U.S. physicians are women. But that 44% goes down to only 36% of first authors of the case reports were women. And compared to the 34% of overall docs, only 25% of the senior physicians, the last authors, were women.
So there's a delta there.
Yeah, there's a delta about 10 points in both.
Right.
That is, you can see that graphically in figure 2, where basically there's this cool little scatter plot where it shows if the numbers were equal, if women were represented perfectly equally, all those dots would be right on the line, nice 45 degrees. It's clearly not. Both are above the line because there's more women trainees and more women doctors than there are first and last authors. They did a bunch of other analyses, things to look at figure 1. They looked in different states, especially because different states like New York have different ratios of trainees to patients in the hospital and stuff like that. Basically found while there was variation, the pattern basically persisted everywhere.
Right, and I guess my reaction to that is different specialties have different workforce, right? We know there are more women in pediatrics. We know there are equal numbers of women and men in internal medicine. And I wanted to know by specialty, and they did a specialty breakdown.
They did.
And they were very different, and maybe you can speak to that, but I didn't see the specialty breakdown standardized against the woman-men split within that specialty or subspecialty. And you can accuse me of being focused on a subgroup analysis as opposed to an overall population. But in this case, where I'm not that worried about making the wrong inference. I kind of really wanted to know how that played.
Right, and I think this may not be exactly what you're asking for. That's basically in table 2, the adjusted odds ratio they're asking for. This was too much small text to put up into a slide, so I don't need to apologize for that.
Right.
But basically, almost every specialty had the same thing where women were underrepresented according in proportion to how much they make up the specialty as a whole.
Right.
There were a handful of specialties that were roughly equal. That the proportional, the workforce proportion and the case report proportion were similar. It was all O's. It was radonc, onc, and ophthalmology, and I think also optometry. It's all the O's except for orthopedics, which is pretty male dominated.
Right.
And it's interesting. And basically, they go through some of the other sorts of secondary and subgroup analyses, but basically show there are some exceptions where things are a little more equal, but overall, this basically holds up in every specialty.
Got it.
And most specialties.
Also looking at table 2, the real presence of women was in speech therapy, nursing, OB-GYN, and dermatology, I think, right?
Yeah, that sounds right.
And so that matches stereotypes. I don't have the data of kind of the proportion of women in those fields. And the broader picture is, these are case reports. I don't quite know what this means.
Right.
Because case reports have a kind of have a questionable, ambivalent relationship to advancing medical information.
Right.
Some journals will publish them just to have interesting clinical material in the journal rather than because it advances information.
Right.
So is that really important?
Right. Yeah. So I think the cynical or devil's advocate take would be something like, well, maybe the women are off doing more important things than publishing case reports.
Yes.
I think this is kind of more just a biopsy of the state of the medical literature that and academics in general, that yes, there's all sorts of good stuff, but the bottom line is in case reports, which do have limited utility or relatively low on the pyramid of
evidence.
There's still pretty and there's a low barriers to entry to making case reports. It's still a disparity there.
Okay.
So
Good
I
to
find
know.
it interesting.
Yep. Check it out on our website, JAMAnetworkOpen.com.
Yeah, so running through the table of contents from last week's release, some other interesting findings. Another study by Dr. Katie Suda, who joined us last week, they looked at appropriateness of antibiotic prophylaxis prescribing among U.S. dental visits. They use a Blue Cross Blue Shield database, which was, I think, about a third of dental visits, or am I mixing this up with the wrong state? No. This one was Truven. Sorry. So they looked at a lot of they looked at a big fraction of private insurance claims for antibiotic prescriptions. They only looked at 2 days prescriptions because anything that's 3 days or more could be for an infection, and that's like 80% of prescriptions. Some of those are probably still prophylaxis, but they wanted to make sure they were looking at ones that are only theoretically for prophylaxis, and found that 81% of them were inappropriate.
Wow.
And most of them were for either prosthetic joints, which used to be recommended to have prophylaxis but doesn't anymore, and other just less risky cardiac things.
Prosthetic valves,
Yeah,
right?
prosthetic valves too. But basically 12 years ago in 2007, the guidelines for prosthetic valve prophylaxis basically became much less prescriptive, I guess.
Right.
And most of the time, there's only a handful of situations where prophylaxis is necessary anymore, or is recommended anymore, just because the evidence of benefit is so small, and the risk for things like C. diff, whose new name I can't pronounce, is so high. And basically, the only times are people who have a prosthetic valve, a prior infective endocarditis, congenital heart problems, or a transplant with valvulopathy.
Got it. And Dr. Suda here last week looked at U.S. versus U.K. dentists and opioids.
Yeah.
So we talked about those findings, that the U.S. Dentists are prescribing far more opioids than their U.K. counterparts. And she pointed out that there's not an infrastructure for guidelines in the U.S. dental profession.
Yep.
And this is a key kind of evidence.
Right.
This is key evidence pointing out why that might be useful. Because if the practice hasn't caught up to the 2007 guidelines, we're talking a 12-year lag. Yeah. Right.
Well, only 5 more years. Only 5 more years to the 17-year. Although some of that's supposed to be the data, not just the guidelines.
Right.
So I don't know.
Right.
Although there is a great quote I heard attributed to Derek Angus that is, it's not that it takes 17 years for people to learn about the data, is it takes 17 years for the people who want to implement the data to be in a high enough position to actually implement the data.
I see. Okay, yeah, for the career growth.
Right, exactly. Okay. And some other stats that came out, and some of this was from the invited commentary that came with this, is that dentists are responsible for 10% of antibiotic prescriptions in the U.S. So the potential footprint of this kind of inappropriate prescribing is huge, especially as we're rapidly approaching the post-antibiotic era. Yeah. And that 60% of Part D prescriptions are for dental infections.
Wow. Okay.
Yeah, or prophylaxis. But yeah, it's craziness.
So, and we had, don't take this the wrong way, but we had discussed previously in one of our broadcasts, I believe, the role of veterinarians in terms of prescribing opioids for animals, for domestic pets, as a source of opioids. And now we're bringing in dentists as our colleagues as being a potential source for opioids in our ecosystem, as well as antibiotics.
Yep.
Wow. So we don't think about that much as physicians. I don't kind of have to imagine what our role is in counseling patients to the extent that we know about their dental procedures, but we could probably stand to develop systems to open up communication with our dentistry colleagues and endodontists and prosthodontists and so on to make sure that we can cooperate on the care of the same patient and prescribe appropriately.
Yep, absolutely. So moving on, the next one is another gender disparity. This one's interesting. They looked at bystander interventions for students who had cardiac arrest in Japan. There's a database which is cleverly named the SPIRITS database to stop and prevent cardiac arrest and injury in trauma in schools. So SPIRITS, which is nice. I always like a good acronym because there's so many bad acronyms out there in studies. And basically, they found of the about 232 students who had an arrest in school in Japan from I think it's 2008 to 2015. 3/4 of them were male, but there were big disparities in who got AED pads placed. So the rates of CPR chest compression were the same, but the girls were much less likely to have AED pads placed.
Is that right?
Especially the older girls, so girls in high school and trade schools. And part of the hypothesis is, you can do CPR without taking somebody's shirt off, with clothing on and stuff like that. If there's, if you're say a male teacher at a school, and we actually know it's kind of hard to tell if somebody's arrested or not, even with medical training sometimes. Is there a reluctance to take somebody's shirt off to put pads on?
Right. And they don't want to compromise maybe the modesty of these young women. But boy, I guess there might be, they don't look at mortality, they're just looking at the process.
Yeah, this was just looking at the process, So just interesting.
And it is interesting. And is there any information about the cause of the arrests? I suspect that's not in there. But why are young people arresting in high school? Like, that's pretty scary, right? Is it asthma attacks or peanut allergies or?
I didn't read the paper close enough to see if they addressed that or not, but I'm sure there are some slices of the Spirit Study salami that address that.
Okay. What do you have next?
Okay, next, this is just an interesting one that I know very little about any of the topics involved, so I'm not going to answer any questions about it. But
so ask away, right?
For patients with IgA nephropathy, tonsillectomy
Yes.
can actually improve their overall nephropathy outcomes and their kidney function long term.
So is it, they don't necessarily have tonsil problems, but it's a prophylactic tonsillectomy.
Exactly. Yeah, doing the tonsillectomy because IgA nephropathy is a problem of the immune system, tonsil part of the immune system, cut that out, patients do better.
Right, so that's interesting. Yeah. I could propose that IgA is one of the surface immunoglobulins in lumina, right? And so I'm probably going much further than I probably should. But I could speculate why that might be.
But it's pretty cool, and it's nice to see some, pretty decent measured outcomes as far as renal function in these patients. It's interesting stuff.
Okay.
But yeah, we're going to move on before I get harder questions about the different IGs.
Yeah.
Next, here's a paper by Eric Topol and colleagues, Trends in Prices of Popular Brand Name Prescription Drugs in the U.S.
Yes.
And did you know that popular prescription brand name drugs are having increased prices in the U.S.?
As Claude Rains would say, I'm shocked.
Right. And they looked at the 49 highest prescribed drugs that had, it was over over 100,000 claims. This was the Blue Cross Blue Shield database, which covers about 10% of Americans, about 35 million Americans, and basically found that 78% of them had substantial increases in either the insurance copay or the insurance payment and the out-of-pocket payment, and 44% overall, and more than doubled in price.
Wow. And there's a compelling figure that shows a graph, then the x-axis is time and the y-axis is price, and there's a cluster of all of these drugs that kind of in the middle, and then the real outliers. And I forgot what is the most, the winner in terms of highest increase in price over time, but they're all drug names that you're familiar with.
Yeah, and there's two graphs interesting too for both Humira, and Humira just does this kind of like scallop step-up approach.
Yes.
And then insulin, which has been in the news a lot recently, which basically went up and then kind of plateaued at a slightly increasing rate. But basically, it's going up. And what's interesting here, I think the thing I found most compelling was that they didn't just use like the MSRP numbers. They used actual claims data, so how much insurers are paying and how much patients are paying out of pocket. So these are the numbers that matter. And if you say the word cost in a health economics or health policy area, the first thing that people do is roll their eyes and say, well, what do you mean by cost?
Right.
And this, I think, what they used for cost was a very good metric.
Got it. And Uwe Reinhardt, the health economist who unfortunately passed, I believe it was last year in early 2018, has said years ago, it's the price is stupid. Things just cost more in the United States. We have a system that at least allows that if it doesn't facilitate and encourage that. And that is a contribution to the growth in healthcare expenditures more generally in the U.S.
Absolutely. Next up, this is another one that's just kind of interesting physiology stuff to me, is that association of serum cholesterol levels with peripheral nerve damage in patients with type 2 diabetes. So they did MR neurography, which is a fun word to say, on patients with type 2 diabetes, and found that there was an inverse correlation between cholesterol levels and peripheral nerve disease lesions. So basically, patients with diabetes, this is a surrogate marker or a disease-oriented marker, not a clinical outcome, but basically they had more nerve lesions with lower cholesterol levels.
With lower cholesterol levels.
Yeah.
Okay.
So usually all this stuff is kind of collinear, right? People, the metabolic syndrome X stuff all goes together as a whole. And in this case, there's been a lot of I'd say attention or movements towards aggressive management of all risk factors in patients with diabetes, and that this might suggest that we might find out that some of that might actually be detrimental in certain ways.
And what do the authors propose as a mechanism, or did they not go there?
They probably went there, but I think my eyes glazed over, and then I woke up a few minutes later.
Okay.
Right. Next up, another one a little bit out of my wheelhouse, but there's now this transoral endocrine surgery approach where you can basically do thyroid or parathyroid surgery through the mouth from the inside, with a big advantage potentially of being scarless. I think we've all seen patients with thyroid scars.
Yes.
Oftentimes they're very subtle, and they can generally kind of roll into the creases of the neck pretty well, but it's still a scar. People don't necessarily like scars. And they basically, apparently people underestimate how many patients are potentially eligible for this surgery or for the surgical approach. And they looked at 1,000 different thyroid and parathyroid operations at 3 academic medical centers. And according to their criteria, 558 of those patients were potentially eligible. Not that it was a missed opportunity, but just kind of going forward as this surgical technique becomes more widespread, that at least half of patients appear to be eligible for.
So this is a consciousness-raising surgical epi study in a way.
Yep.
And do you know the eligibility criteria, or should we not get into that?
We should not get into that.
Okay, very good.
Right, nice. Although my thyroid surgery and colorectal surgery has a special place in my heart because my first month of third year...
Special place in your thyroid and in your colon.
Yeah, no.
Yeah?
Yeah. It was, but my first month of third year of med school, so my first real clinical month was thyroid and it was endocrine and colorectal surgery together.
I see.
Yeah, it's called Team 3. It was a good surgery month.
Okay.
Yeah, it was good stuff. All right, so next up, this is another kind of interesting one. So the association of preoperative renin-angiotensin system inhibitors in preventing post-op Afib in patients getting cardiac surgery. There's a systematic review of meta-analysis.
Okay.
So basically, patients with cardiac surgery, about a third of them after CABG go on to have post-op Afib. Post-op Afib is associated with all sorts of badness. I think it's probably, if nothing else, a marker of some sort of sickness or complication from the surgery. There'd been some thought as far as some other science that showed the renin-angiotensin and aldosterone system axis was involved in that. They looked at a bunch of studies, did a systematic review meta-analysis, and found that there was no improvement in post-op Afib with any of the renin axis medications. So they are not the new beta blockers.
Okay, and these are ACE inhibitors and aldosterone antagonists, presumably.
Yep.
And This is, were these randomized trials in the meta-analysis, or were they observational studies as well?
I don't know.
Okay. I feel like a great pitcher.
Right. Yeah. There's only so much space up here. And, I'm trying to go out of my wheelhouse, not just do, opioids, alcohol policy,
No,
and
it's
emergency
good. Yeah.
studies. But yeah.
Okay.
But yeah, it's just interesting. It's also, I think, there's something to be said for doing science and the answer being no, we're wrong. This
No.
idea didn't work out.
That's great.
We should all talk about our failures more.
And an open access journal is a perfect place
Yep.
for those kinds of studies. We love all kinds of studies,
Yep.
as long as they're good science, but it's a good place to get the information out there that might not be as attractive to other kinds of journals.
Yep, absolutely. So, of course, that's it. You can check out these papers and more from Friday's release at JAMAnetworkOpen.com. Everything's free and open access. Follow us on all the usual social channels, Twitter, Facebook, LinkedIn, Pinterest at JAMA Network Open. And join us next week, Monday at 2 p.m. Central Time again.
And the soundtrack to this broadcast will make it into our podcast feed. So subscribe or listen to the JAMA Network Open Editor Summary. You can get that wherever you get your MP3 downloads, iTunes, Stitcher, Google Play, Spotify, and more. Check out our Spanish translations and simplified Chinese translations of our titles and key points. And Seth, I looked it up, and I've been saying that we release every Friday at 10 a.m., which is Greenwich Mean Time -5. And I looked it up, and we're Greenwich Mean Time -6. So I want to correct all my past misstatements, but I'm really only off by an hour.
Right.
So thanks for joining us. Leave comments beneath these videos on any of the platforms if you have any questions, and we'll try and respond throughout the week. Thanks for joining us, and we'll see you next week.
All right. Thanks. Take care.
Take care.